All right. Well, my clock says noon, and out of respect for everyone's time, I'd like to go ahead and get us started. Welcome, everyone, to the third Diversity Health series that we are having this year. We have put on this series in order to try to increase the cultural humility and cultural competence of our healthcare workforce. So we are absolutely delighted to have you here today. I'm going to go over just a couple of housekeeping items, and then I will go ahead and introduce our esteemed speaker. If you are here and you need continuing medical education credits, Dr. Doherty will be putting a link in the chat. It's all online now. And then you follow that link, fill out the evaluation form, and it gives you a code so that you can name your needs. As you can see, we are recording this event, and the slides will be available on the Office of Diversity and Inclusion website. The recording might just take a little bit of time so that we can get it captioned so that we have that accessibility. If you are a POM student, I'm so glad to have you here. The reflections on this Diversity Health series will be due this Friday via Canvas by 5 p.m., and I look forward to reading those. And if you have any questions during the event, we ask that you go ahead and put them in the chat. Dr. Doherty and I will be helping to moderate the conversation, and we will let Dr. Packham know what your questions are. So with that, I'd like to introduce our speaker. Dr. John Packham is the Associate Dean for the Office of Statewide Initiatives, as well as an Associate Professor in the Department of Internal Medicine at the University of Nevada, Reno School of Medicine. He received his bachelor's and master's degrees in sociology from the University of Oklahoma, and he has a PhD in sociology from Johns Hopkins University, which he received in 1992. Dr. Packham has co-authored nearly 100 policy-relevant statewide research reports, including the 10th edition of the Nevada Rural and Frontier Health Data book that was published in this year, as well as the 5th edition of the Healthcare Centers in Nevada, published in 2020. For over 2 decades, he has served on numerous statewide boards and commissions, including Governor Sisolak's Patient Protection Commission. And in 2020, Dr. Packham received the Nevada Public Health Association's Public Health Advocate of the Year Award, which I think was very well deserved. Today, he's going to be speaking with us about how to focus on upstream factors, and specifically, he's going to be talking with us about race, class, and how to try to struggle towards health equity. So please help me welcome Dr. Packham, and at this point, I turn it over to you.
All right, thanks, Nicole. When Nicole asked me if I would speak several months ago, I had this delusion that we would maybe all be on campus at that point. And of course, that was a crazy thought, and it still seems kind of crazy now. So next time we'll do this on campus, but I'm pleased to join you on a set of topics that I've been thinking about and studying and reading about literally for decades. A couple of notes, disclaimers, if you will, on my background. I'm not a clinician. I'm not an epidemiologist. I'm actually not even academically trained in public health. Nonetheless, I've had a longstanding interest in public health, and it helped that my first job was at the Hopkins School of Public Health at a really interesting time. It was the Clinton healthcare plan was taking off, and a lot of our faculty members were involved. So got really interested in policy and public health policy and so forth at the right time. One of the things that I want to kind of mention from the outset is one of the most consequential years of my professional, personal life, for that matter, was a year that I spent in Sweden. I did a postdoc in a little town about 200 kilometers west of Stockholm called Örebro. And one of the things that Sweden taught me was that a society that is committed to health equity was also a society committed to improving overall population health. I never got the connection between improving overall public health and health equity until I spent that year in Sweden. And what Sweden embodied, and will be a theme that will run through the discussion today, is as Paul Wellstone, the late senator from Minnesota, put it succinctly, we all do better when we all do better. Now, there's a couple of things about Sweden I would also add is that health equity is not an issue that solves itself. There's no magical market mechanism, for example, that creates health equity or a society that values that. One of my great concerns right now in this country is that you cannot legislate social solidarity. And we're at a time in which the buzzword is that we're polarized. I tend to view it a little more differently and a little more critically, and that is various parties and factions of those parties have no interest in health equity. It doesn't rise to an issue of concern. And so that we think about what will be necessary to move us on, at least in a progressive way, towards a society that's characterized by greater equity and health equity. It's going to take policy, and it's going to take, I'm afraid, solidarity that is sometimes in short supply in this country. So, in framing our discussion, I'd like to just point out a couple of terms that I'm going to draw on. I hope I use them consistently over the next 45 minutes or hour. But when I think of the distinction between equality and equity, equality assumes that everyone benefits from the same supports, that is to say, equal treatment. In contrast, equity and social justice, I would add, requires that everyone gets the supports they need, that is, differential supports. In the simplest terms, in a way I will like to think of health equity, it simply means that everyone has a fair and just opportunity to be as healthy as possible. I want to kind of quickly go through some terms that I will use throughout. And again, press me if I'm not using these consistently. I like to make the distinction between health disparities. Another word for health disparities is health inequalities, that is to say, differences on an endless number of health and healthcare metrics. And just kind of, again, make that distinction between disparities on one hand. For example, for the last 100 years, women have had a life expectancy advantage over men in our society of 3 or 4 or 5 years. That's a disparity. I don't know if we would call that a health inequity. I like to think of inequities as inequalities that are in some respects preventable. And pretty much everything I will discuss today are items, not to say that they're easy to prevent or reverse, but in principle are technical matters. They're public policy matters that we can change if we have the wherewithal to do that. I also, it will hopefully become evident throughout this discussion that I take social justice matters quite seriously. In fact, I argue that social justice is a key feature of public health practice. When you're taking the population's health as a serious concern, you are almost by default taking equity and inequities as serious as well. I believe in my heart of hearts that justice exists when systematic barriers or individual barriers have been removed or eliminated and the root causes of inequity are addressed, okay? So the path to equity means the removal of those obstacles that include poverty, discrimination of all types, addressing powerlessness in society, addressing the lack of access to good jobs with fair pay, ideally that come with health insurance and so forth. So that again, we talk about equity, you're talking about the road to social justice. I'm also going to draw kind of a comparison between the importance of race and structural racism as a key determinant of health, as well as qualifying that with ideas about social class and the relationship between social class and life chances. There's a long, rich academic history of interest in social class going back to at least Karl Marx and Max Weber in Europe, and their interest in the importance of class, the least of which was the impact of social class on life chances, including health outcomes and so forth. When I speak of the term race and structural racism, it's not going to come as any surprise to you, given you now know I'm actually academically trained as a sociologist, that I will use the term race and racial groups almost exclusively in social terms. That is, race is a social construction more than it is a biological concept. Likewise, I will refer to structural or institutional racism to refer to race-based unfair treatment of groups that are baked in or built into policies, laws, and practices. To a sociologist, something that is structural means it's as enduring as a building or a road or a sidewalk. It is an ingrained part of our society. Again, I plan on teasing out these two, and I'm going to try to come to the conclusion that, and it's kind of a part of a stale academic debate, what's more important, race and structural racism or class and class exploitation? They're both important. The key is understanding the connections between those two. Also, a little footnote, at the risk of sounding a little cranky, I'm going to try to be precise in my use of the terms epidemics and pandemics. Everything these days is called a pandemic. And at the risk of, again, being a little bit cranky, I'd like to really use and restrict the term pandemic to what we're facing with COVID-19. Pandemics are noted in that they're rare, okay? The influenza pandemic of 1918 is a good example. The last couple of decades of HIV/AIDS, global in nature, everything is not a pandemic. So let's get into this. First slide I want to share with you is one that I shared, interestingly enough, interesting experience. I shared this with the Legislative Committee on Healthcare a couple of years ago, and I was trying to make a very quick point that zip code is more important than your genetic code. If you haven't seen this map, great map put together by the Center for Society and Health and the Robert Wood Johnson Foundation. And they did this for a couple of cities. Loved this one just because it was kind of homegrown. And what ended up happening is that the committee loved it. Senator Spearman stopped me for 10 minutes and we talked about this map. And I think I'd forgotten at the time how striking this map is with respect to illustrating that opportunities to lead a long and healthy life are literally tied to the neighborhood you are in. Gaps in health across neighborhoods, in this case Las Vegas, can stem from a variety of factors, from scarce educational and income opportunities to things like unsafe or unhealthy housing, to, of course, limits to what we're all reading about now, and that's access to care, or primary care that's not 3 bus rides away from your place of residence. In this particular map, I just point out, we look at a number of things, but it's the case in Las Vegas, or it was, I think these numbers still hold up. These are a couple of years old now, that life expectancy can differ as much as 16 years in the 9 miles, for example, that separate zip code 89109 on the east side of the Strip to southeast Las Vegas, represented by zip code 89183. If you look at a couple of features of the 89109, there's more renters than homeowners. It's a majority non-white neighborhood. Average household income under $40,000. In contrast, zip code 89183, has more homeowners. It's majority white. Household incomes in excess of $65,000, among other differences. Again, great way to have us dive into the issue of the relationship between social determinants of health and the subject of our discussion today. I want to start off the discussion, have you think about the relationship between social position and health, social structure and health, and the way those determinants of health, which we'll touch upon throughout, literally are structured. And I wanted to share some research that was actually starting to come out as I was leaving graduate school and starting my professional career in the late 80s and early 90s. And it's a set of legendary studies. If you haven't heard of them yet, encourage you to take a deeper dive into what are called the Whitehall studies. The Whitehall, or the term Whitehall, refers to a study of, at its origins, 18,000 men in the British Civil Service. It was set up in the late 60s and continues to be undertaken over multiple decades by Michael Marmot and colleagues in Great Britain. Actually, he's Sir Michael Marmot. He was knighted a few years back. His record is that impressive. And the Whitehall study showed at its heart that men in the lowest employment grades were much more likely to die prematurely than those in the highest grades. And of all the people in the study, it's important to note that is, these civil servants had access to medical care. None of them were impoverished. Still, if you looked at this group over time, there were substantial differences in the lifespans of junior and senior employees in the British Civil Service. Still holds to this day. And at the end of the day, those who had more money, who had attained a higher rank, lived substantially longer lives. Share just a couple of slides from this body of research and highlighting the social gradient in health. This particular figure, really simple, straightforward depiction of death rates for each grade in the civil service relative to the average for the entire civil service population. So they set the average at 1.0. And what Marmot found very quickly over just a short period of time is that administrators and professionals have a fraction of the overall mortality. While the mortality increases rather as the employment grade declines. Support staff in this depiction have twice the mortality of the entire civil service population. In other words, among British civil servants, mortality was higher among those in the lower grade when compared to the higher grade. The first of these studies, Whitehall 1, found higher mortality rates due to all causes. It's really important. So overall mortality and cause-specific mortality was tied to one's rank in the British Civil Service. What Marmot also found is that gradient persisted over time. This is some data that came out in the late 80s, early 90s, that looked at follow-up of the study at basically 10-year increments or intervals. And what they found is the gradient persisted. That is to say, at each follow-up period, what we found is just the striking mundane nature of the gradient. A little bit of a break in that 10 to 19-year follow-up. But at the end of the day, the higher the rank, the better the health. Moreover, the relationship persisted when you adjusted for age and risk factors. That is to say, this difference was not an artifact of one rank being older or younger than the other, nor was it explained by much as a function of traditional risk factors to health, such as smoking, blood pressure, cholesterol, blood sugar levels, and so forth. And finally, just to kind of round out the story, what Marmot and colleagues found out was that there was a lot that could not be explained. So that when you took into account age, you took into account risk factors and so forth, the gradient persisted, and there was still a great deal of that relationship between social position and health that was simply unexplained. What that research has established, and it's been updated, expanded, verified in literally hundreds of follow-up studies and replications in other parts of the Western world, actually in the rest of the world period, is that people with greater social standing or status, that is to say more income, education, occupational prestige, wealth, and so forth, tend to live longer and healthier lives. Moreover, that relationship is stable. What was very interesting about the Marmot Whitehall studies was this was a country that had and continues to have universal health coverage. The British civil servants are not living in a state of, none of them are living in a state of deprivation and so forth. So that again, what we found is the persistence of the gradient. Now, what that research then led to was interest in what else was at play other than social position and social class. And hence, I'll pivot here a little bit and turn the discussion a little more to two things that I think are at play, particularly in the American case when we see widespread disparities in health by race and ethnicity, is wealth as opposed to income, and the connection and the disparities that we currently see with respect to disparities in wealth among racial groups in the United States. Now I'm going to walk you through a couple of slides on racial disparities in wealth before I get into those disparities in health by race and ethnicity, and highlight a couple of things. First, and some of this will be intuitive or obvious, wealth is a critical tool for individuals and families to not only finance but achieve economic mobility, the ability to pursue and change jobs, to pursue education, start a business, and so forth, are closely tied to wealth, and those reverberate across generations to have important influences on health and well-being. Here's a pretty straightforward depiction of the kind of the distinction between race and or between income rather and health. The green bars, dark and light, represent median Black or African American household and wealth and income respectively. The blue lines represent white household wealth and median white household income. And kind of what these depict are a couple of things. One, greater levels of overall wealth when you compare white and Black households. Ditto for income, but they also show that regardless of race, wealth is highly concentrated among the upper parts of both of those segments of society. Here is another important story with respect to wealth as we kind of draw out the distinctions by race and ethnicity. The figure on the left looks at data as basically we didn't collect this type of data prior to the 60s, but highlights again median family wealth. That is to say, half of white households are above $170,000 in terms of wealth, half are below. Compare how striking the differences are by race when we look at Black median wealth versus white median wealth, or when we look at Hispanic ethnicity, again, drawing the contrast between white and Hispanic households. And there's a number of striking things about these data, but one is that the gap in wealth has actually widened over time, regardless of whether you look at white-black differences or white-Hispanic differences. And again, just the striking magnitude, a factor of 10 for the most recent year that we have data when you compare white and black median wealth. Also want to point out kind of a busy slide here, but that and again, I'm going to just be trying to make the case why we need to be paying attention to wealth. And that is when we look at differences between white and black Americans in terms of wealth. Yes, education matters. Yes, marital status matters, age, and even income. But each one of those levels, if you look at just those individuals with a baccalaureate degree or more, white household wealth is greater than black or African American wealth by a factor of 4 or 5 or 6 in some cases.
Dr. Packham, can I
Yes.
interrupt you? There's 2 questions.
Yes, please interrupt me.
First of all, were the data collected from the census or from some other source? And the second question is how wealth was defined in the study?
Yeah, great questions. Most of this data is from the Federal Reserve System. That's an interesting place that I would have never guessed until I started looking at their data. They've been collecting data on household wealth for over 60 years, close to over 60 years. And it's actually a rich source of data that speaks to not only economic inequities among groups in society, but they also have an explicit agenda to address disparities in wealth. Now, wealth, don't like to overcomplicate it, but as opposed to income, that is the amount of money you receive, typically gauged over the course of a year. Wealth is basically all of those material and financial assets that you have at your disposal. Your car, the equity in your house, how much liquid assets you have in a bank account, a savings account, or a checking account, the amount of value that you have in your retirement plan, et cetera. So it's material assets that are kind of to be distinguished between your amount of income at a monthly or an annual level. Does that make sense? Hopefully that does. So I want to continue and kind of move on a little bit quickly, but try to highlight the difficulty or the disparities, not only in just average wealth by race and ethnicity and the way that varies in society, but also highlight some of the obstacles to building wealth. This is, again, a study done by the Federal Reserve System that looked at median wealth for a cohort of white and black Americans that they tracked over time. And what they found is a couple of things. Again, disparities in overall wealth, but also disparities that persisted over time as that cohort, differences in their ability to amass wealth. If you look at what was going on in 2009, you see a drop there as a result of the recession of 2008 and 2009, but you also see a pretty strong rebound for white households. And so not only the ability to amass wealth, but the ability to respond to adversity is borne out by that. The final slide I want to show you, and we think about opportunities or ability to build and amass and transfer wealth. Home ownership is an absolute key to this story. A somewhat depressing slide in that, again, for as long as data have been collected, there have been very persistent disparities by race and ethnicity in home ownership, and that disparity has not changed literally for decades. I now want to turn given the time to matters of health, which is, I think, what brings us all here, and talk a little bit about some information in a great study. This is from Paula Braverman and colleagues, study, actually a very succinct study called Wealth Matters for Health Equity. And what they tried to highlight in this particular study is, again, kind of that linkage of discussion of wealth disparities with what I will speak to in a moment with respect to health disparities, again, by race. Those health disparities will not be a surprise when we kind of think about disparities in wealth and the way that those disparities are perpetuated over time, in part through mechanisms such as structural racism, but I will also argue the disproportionate class disadvantage of Black as opposed to white households. More on that in a moment. What Braverman and colleagues argued was that parents' wealth shapes their educational, economic, and social opportunities, which in turn shape their children's health throughout the course of their lifetime. Wealth can be passed down directly to subsequent generations through inheritance, through gifts, through a parent bequeathing a home or property to a child. These direct transfers, however, play a smaller role in transmitting wealth across generations than compared to the roles played by educational and other opportunities, again, structured socially. Just as I noted with that earlier map on life expectancy by zip code, parental wealth shapes the quality of neighborhood and social context within which children grow up, which in turn can affect sources, supports, and cognitive stimulation available at home. Children in more economically disadvantaged families typically experience more limited educational and social opportunities, in turn limiting their chances for economic advantage, and I would argue good health as adults. In other words, along with inherited wealth, health is transmitted across generations through material and psychosocial advantages. Now, the next set of slides will highlight some of these disparities in health that I argue are fundamentally tied to wealth and the sources that and factors that create that different disparities in wealth in American society. So, data you might have seen or become familiar with, a recent report from the National Center for Health Statistics. This is pre-pandemic, so be prepared for this data to change over the next couple of years. What it highlights is kind of a good news, bad news story, and that is across most racial and ethnic groups, with the exception of Native Hawaiians and Pacific Islanders, a slight decrease in infant deaths per 1,000 live births, but striking differences, particularly when you look at disparities between white and Black groups and white and American Indian or Alaskan Native groups in society. Moreover, if we look at not just a year-over-year snapshot, but a longer period of time, this data from the same source, National Center for Health Statistics, highlights disparities across racial and ethnic groups in American society. The striking thing about data like this is that they don't change that much. I think there's been some attenuation or decrease in the gap between white groups, for example, and Black, or white groups versus American Indian or Alaskan Natives. Those disparities have not changed a great deal. There's a lot of information in that, but again, the highlight is striking disparities over time. We also look at something clearly tied to infant health. That is teen birth rates. Again, we see very similar disparities. The color coding on these bar graphs, by the way, are the National Center for Health Statistics, PACM. I don't know, honestly, how they do the color coding, but again, corresponding to the previous rates that have gone down for all groups. That's a good story, but the persistence of those disparities is kind of the name of the game there. Likewise, important, long-standing historical disparities in terms of preterm birth, so that when we think back on those infant mortality slides, more births among teenagers, differences by race and ethnicity, as well as preterm birth, which we know is closely tied to the availability of prenatal care, to social conditions that are responsible for preterm birth. One last slide before I get into coronavirus was one I literally happened upon last week, and kind of moving away from infant mortality and related factors associated with infant mortality is a report that came out from the American Heart Association right before the end of the last year, looking at structural racism as a fundamental driver of health disparities, in this case, cardiovascular disease, and just a great one slide snapshot of differences between non-Hispanic whites and Blacks, Hispanics, and Native American Pacific Islander groups. Good news is that across each one of these groups, we see a steady decline, maybe a leveling off, unfortunately, in cardiovascular disease mortality. But again, very striking differences in those groups from what those levels were in 2007 across groups, as well as striking disparities for the most recent year, which was 2017. Now, I'd be remiss if I did not include a few slides on how disparities in health have been revealed by the COVID-19 pandemic. I'm going to really motor through these and encourage you to reference some of the sources that I've listed at the bottom of these slides. There is a wealth of information, both at the state level here in Nevada, as well as the national level on disparities in race and ethnicity. Now, at the risk of sounding like a smarty pants or a know-it-all, these don't surprise anyone who has been looking at racial and ethnic disparities in this country over the last couple of decades. If there's one silver lining to the COVID-19 pandemic, though, I would argue is that these disparities are exhibit A in why health equity matters, and why, if we don't attend to things like disparities in wealth, disparities in economic opportunity and educational opportunity, these disparities will continue to haunt us. This is looking at death rates by race and ethnicity, great national source. That's the APM Research Lab, which has been documenting this since the middle of the summer. And again, striking death rates. It's staggering to think that among Native Americans, 1 in 475 in our country have perished as a result of COVID-19. There's no good number in this slide, but the disparities are very striking. Here is another set of data a little closer to home that looks at some key COVID-19 metrics. I limited it to confirmed cases, deaths, and then some really limited recent data on vaccination, again, looking at it by race and ethnicity. I want to give props to our Nevada Department of Health and Human Services, who very early on began making sure that localities, local health authorities, local health facilities were collecting data and breaking it out by race and ethnicity to document what we always fear, and that is whether we look at confirmed cases, the number and percent who ultimately die, and now more recently vaccination data, what we again see are important disparities by race and ethnicity. Kind of the reference point as you look at this slide or take a closer look at it later. On the left, you can see that whites, non-Hispanic whites make up a little less than half of the population. And they, interestingly enough, while have fewer confirmed cases right now, have a disproportionately higher number of deaths. On the other hand, there are also vaccination rates that are different, again, by race and ethnicity. And what you kind of see and hopefully think about here is just the differences between how COVID-19 is revealing or unfolding in Nevada, and how that differs in terms of what our overall population makeup looked like prior to the pandemic. Here's a final set of data, another great data source. This is a national tracking project organized by the Atlantic Monthly Magazine and Boston University that has some quite good state level data. And here they take a closer look at death rates as well as case rates and kind of disparities between race and ethnic groups here in Nevada. I always point out that this data is sometimes limited and should be treated with some caution because a lot of people don't report that. That is another legacy of structural racism in our country, is the hesitancy of people to self-identify when getting a lab test and so forth. We're a little bit better at tracking that by coroners' offices and those completing death certificates. But again, with those limitations, some important differences here among race and ethnic groups that really leap out at you. More cases among Hispanics, Asian groups, and Blacks as compared to white. Surprised to see fewer cases per 100,000 population for American Indian and Alaska Natives, but you can kind of see higher mortality or death rates despite those lower numbers of cases. And then my final COVID-19 slide is one that, again, I found a couple of weeks ago, and this has been borne out by an even more recent CDC study that is looking at some estimates of COVID-19 impacts on life expectancy for the population as a whole, if you look at the left side of this slide, and then breaking it down for non-Hispanic Blacks, non-Hispanic whites, and Latinos. And what is striking and somewhat disturbing is that this data and the more recent CDC report have highlighted that life expectancy in this country for all groups has not only leveled off in the last couple of years. The deaths of despair is kind of the common explanation for that, and causes of death related to the opioid epidemic, among other things. But the really striking thing with these estimates in the CDC data is the pretty dramatic drop in life expectancy when you break it out by race and ethnicity. For all groups, including whites, the rate declines. But if you look at and take a closer look at this study, I encourage you to do, you see Black and Latino death rates dropping by a factor of 2 to 3, rate greater than white populations there. The jury's not in on this, but the preliminary estimate does not look good. I now want to kind of close my discussion by talking about upstream versus downstream determinants of health and what those implications are for strategies and public policy to address those factors as they affect health. Forgive me if you've already heard this story, but this is a great one I heard in my very first medical sociology class too long ago to repeat, but it's an anecdote from the great medical sociologist Irving Zola, who relates a story of a physician trying to explain the dilemmas of modern medical practice back in the 90s. I believe they still hold today. And Zola was quoted as saying, you know, it sometimes feels like this. There I am standing by the shore of a swiftly flowing river, and I hear the cry of a drowning man. So I jump into the river. I put my arms around him, pull him to the shore, and apply artificial respiration. Just when he begins to breathe, there's another cry for help. So I jump in the river, reach him, pull him to shore, apply artificial respiration, and then just as he begins to breathe, another cry for help. So back in the river again, reaching, pulling, applying, breathing, and another yell. Again and again, without end goes the sequence. You know, I'm so busy jumping in, pulling them to shore, applying artificial respiration that I have no time to see who in the hell upstream is pushing them in. So we think of upstream determinants of health, think of everything shaded in the blue to the left of the healthcare system. Now, I'm presuming that you and I, either as students or employees of the School of Medicine or some connection with healthcare, largely operate in realms, important realms, to the right side of this particular diagram. That is to say, we are concerned about healthcare systems, healthcare policy, medical education, and addressing issues of racism, structural discrimination, and structural racism by the silo that we are in. And I don't think I'm telling you anything that's new, but speak of upstream determinants of health and related policy, typically thinking of moving right to left in this particular diagram. One's not important, more important than the other, but the totality need to be reckoned with if we are going to make progress on matters of health equity and factors responsible for health equity. So for PACM, and I think for a lot of others, focusing upstream means and reducing health disparities requires addressing obstacles that allow everyone to have a fair and just opportunity to be as healthy as possible. I pulled this information again from that great monograph, Wealth Matters for Health Equity by Paula Braverman and colleagues. And there's two things she really, they want to point out in that is, first, achieving health equity requires attention to those upstream determinants of health, but it also requires deliberate attention to public policy. So that when we think about addressing disparities in COVID-19 cases, mortality, outcomes, and so forth, yes, it's important to pay proper attention to healthcare, particularly the way we roll out vaccines. But those racial disparities in health and health outcomes will continue to repeat themselves in future epidemics, God forbid, future pandemics, if we don't address equity matters as simple as increasing the minimum wage, removing asset limitations on those trying to become eligible for welfare assistance. We don't expand childcare supports. The pandemics revealed the price we pay for things as simple as paid sick leave. Okay, I've had the great privilege as a university faculty member to write out the pandemic from my living room. Okay, there are huge segments of our society that don't have that privilege, that are penalized simply for living in a pandemic and so forth. Now, after all of this cheerful information I've shared with you, I'm going to try to end this on a slightly upbeat note. and argue that I think where we are right now, partly as a result of the pandemic, but also as part of I would say, a longer political shift in our society, is a recognition, among other things, that some problems, including responding to a pandemic and preparing for future pandemics, require some level of government action. Now, don't mistake me. There is a lot of pushback on that. There's bills before the Nevada state legislature right now that would limit a governor's ability to declare a public health emergency in 15-day increments. Okay, I don't think that bill may not even get a hearing. It's so preposterous. Nonetheless, I think there's a sentiment or a shift in society to take government more seriously and recognize that things like responding to a pandemic, reversing the pandemic-related recession and so forth require some type of government policy at some level. What I think that portends for those of us interested in reducing health disparities and moving towards the goal of greater health equity is that there's more appetite to address those issues that have frankly been ignored by the bulk of policymakers at both the state and federal level. That is addressing structural discrimination of all types, not just race and class, addressing income inequality and opportunities to build wealth. There are approximately 700 billionaires in this country that have seen their net wealth and worth, if you will, increase by close to $1 trillion. Okay, that unconscionable expansion of income and wealth inequality will only be tolerated so long. I think there will also be policy measures to address disparities in opportunity, particularly as they're tied to education, jobs, and housing. And then finally, you only advance equity by addressing disparities in political power and participation in organizations and realms outside of government right now. There is a massive move among states to not only preserve the expansion of voting rights that resulted from the pandemic, but extending those further. I think a majority of states are finding out, wow, voting by mail was not that complicated. It was effective, and despite what you read on some cable news channels, they were free and fair. I think, again, the environment has changed dramatically in a couple of years, and think that those changes are conducive to health equity.
Dr. Packham, is this a good spot to interrupt you for a few questions?
This is a great spot, and I think the only thing I would add is I'm referencing an article everybody could be forgiven to have not read this summer because our lives were turned on their head. It's a great one by Don Berwick on the moral determinants of health. And I'm going to use that just to say that the existence of inequality does not necessarily guide us in action. That must, there's a moral component to that, and that fire needs to be lit to get that conversation moving and to address these. And so I'm going to go to my very last slide and open it up for questions.
All right, thank you for a fantastic presentation. This has been really enlightening. And I'm thinking, you know, for the role of a clinician, that slide earlier where it showed that 20% of health outcomes are really around kind of clinical behavior. Other than awareness and advocacy, which are huge, what can healthcare providers do to move the needle on these issues?
I never miss the opportunity to make the point that clinicians have a privileged opportunity and bully pulpit, if you will, to speak to these issues. Please don't look at my at that slide and conclude that healthcare is only 20% of the solution. There are still some pretty damning inequities in access to healthcare, access to things such as testing and vaccines, as we've seen over the last year. And I feel like those are like the final insult of being in a disadvantaged position in society, and that clinicians play a very important role in addressing what is within their realm. Clinicians might have a say on minimum wage law, but one thing that you're in a great position to do is to guide vaccine policy. And I would argue, despite disparities in vaccination distribution and rollout, the discussion at both the state level and the federal level is taking equity seriously in a way that I've never seen before. May not be that may not be satisfying to some, and that dissatisfaction is understandable. But equity is a key part of federal policy now. Depends on who's in the White House and how that rolls out. But even executive orders on health equity are seeing the light of day that haven't. I've never seen them before.
Thank you.
And clinicians have a role in that.
Thank you. Let me read you a couple of other questions. Yep. Is there a concern that the negative economic impact / job loss / housing loss since the start of the pandemic will further expand that wealth difference between racial groups? If a particular minority group had a higher rate of employment in food service, restaurant, hospitality, then the debt accumulation in that group might be even higher than it was prior to the pandemic.
I'm not only worried about that happening, that is happening. And I'm sad to say that. And part of that is revealed by data on employment and earnings, which is readily accessible. But think back to those disparities in wealth that I highlighted earlier. If one segment of society has 10 times the average household wealth as another segment of society, it stands to reason that the ability to bounce back after what we're going through, both the health and the economic damage inflicted by the pandemic, will just move slower. I think that one of the perverse things about wealth disparities is that they get compounded during economic downturns, and inequalities are made worse. They're not made better as a result.
Thank you. There's just one last question here, but I wanted to let people know that the CME information is in the chat. There's a link for directions on how to go about claiming your credits, a link to the evaluation for this event, and you have 30 days to claim your credit on this online. And actually, there is another question here. So, what is our most viable route to improve minority wealth, particularly for Black households, in your view? And I'll leave just the last 2 minutes for you to answer that question, Dr. Packham. Thank you.
Okay. Realize this is Packham's opinion here. I think it's home ownership. I think home ownership represents the most enduring, tangible asset an individual can possess in his or her lifetime, and one that you can pass on to subsequent generations. And that even thinking about the wealth of my father and my father's father or grandfather, the one thing that we have been able to do is pass along household wealth in the form of real property. And so making home ownership affordable. And there's so much policy there that needs to be considered on that. That's related to income and employment opportunities, to be sure. But and that's why the Federal Reserve, by the way, is interested in all of this, because the Federal Reserve plays a central role in expanding home ownership and reducing inequities among groups in society. They're more progressive than I would have ever thought.
Thank you. I just want to thank you once again for putting together this amazing presentation. You are getting a lot of thanks and praise in the chat. Just a few last housekeeping notes. The PowerPoint has been uploaded in the chat. The CME can be accessed through the links in the chat, and you have 30 days to do so. And some people are asking about the recording. Once we are able to get captions on this, which takes a little while, I apologize for that, we will be uploading it to the Office of Diversity and Inclusion website. So thank you all for attending. Thank you, Dr. Packham, for putting together such a wonderful, informative, and important presentation. And I hope you all have a great afternoon.